It's my pleasure to introduce my colleague Devraj Sukul, who's going to talk to us about cardiac rehabilitation. Dr. Sukul earned his degree in medicine at Case Western Reserve. He completed his internal medicine residency at Brigham and Women's Hospital in Boston, and completed his general cardiology and clinical research and interventional cardiology fellowships at Michigan Medicine before joining us on the faculty here. He's board certified in cardiovascular medicine and interventional cardiology. His areas of clinical interest and expertise focus on performing cardiovascular percutaneous interventions to treat coronary artery disease and the management of valvular heart disease and structural heart disease. Dr. Sukul is going to speak to us about predictors and variation in cardiac rehab after Tavr. Devraj, will turn it over to you, and thank you very much.
Thanks so much, Mike. I appreciate the opportunity to present some of this work from our state's own data. And it's obviously hard to follow a great talk by Dr. Arnold, a very informative talk. But I think this hopefully is a nice segue, especially in her slide, touching on post-Tavr care and the role cardiac rehab, the important role cardiac rehab, I think, can play for our patients undergoing Tavr. Let me see, you are controlling. Perfect. I also want to highlight many of the contributors, hopefully many of whom are on this phone call here that helped with this work. And I'll try to leave some time for questions at the end, and certainly try to end before time as well. So quick introduction here. There's been a lot of research on Tavr over the last 15, almost 20 years since it was first done in man. But in terms of post-Tavr care and kind of randomized trials and empiric evidence suggesting what we should or shouldn't do, there's a general dearth of it. And the best thing we have is an expert consensus document in 2017 that kind of fundamentally said the post-procedure care and long-term management after Tavr should probably be similar to that of SAVR, and should include cardiac rehabilitation. And CMS expanded the indications for Tavr, or frankly, the reimbursement for Tavr, or for cardiac rehab after cardiac conditions in the early 2000s from just coronary disease related conditions to include those with valve replacement. I think at the time, because it was before Tavr was ever performed, they didn't expect a percutaneous valve replacement approach to be included. But nevertheless, cardiac rehab after Tavr or after any percutaneous valve intervention is covered by CMS and thus most private insurers, despite evidence really for its efficacy in this population. So this touches on a relatively recent study done very well by a group out at Vanderbilt using pretty sophisticated methods looking at a Medicare population undergoing cardiac valve surgery, and demonstrated, as has been done for principally coronary disease conditions, PCI, AMI, CABG, that cardiac rehab has pretty substantial benefits, in this case showing a reduction in cumulative hospitalizations on the left and decreased mortality risk after doing their best to account for selection bias in this retrospective study. And very similar in coronary disease conditions, cardiac rehab has been shown to at least reduce cardiovascular mortality, hospitalizations, and improve quality of life. So what we sought to do was try to understand the association between some patient demographic, socioeconomic, and clinical factors with cardiac rehab participation after Tavr, an area really which is just starting to burgeon in terms of evidence, and to quantify patient and hospital factors associated with the variation in cardiac rehab use after Tavr, particularly hospital level variation, as we're, as a quality collaborative, trying to improve everyone and really raise all boats, if you will. So what we did was we took the Michigan or MISHC Tavr registry based on the TVT data, going from January 1st of 2016 through Q2 of 2020, and there were 8,600 Tavrs performed in that time period, and linked it to administrative claims. And these claims come from one of the other Blue Cross Blue Shield funded quality collaboratives called the Michigan Value Collaborative, with their mission really being to improve healthcare value as defined as not only optimal outcomes, but at essentially the lowest expenditure possible. And they do a lot of their data with administrative claims that include Medicare fee for service, as well as you can see over here, Blue Cross Blue Shield PPO, HMO, and Blue Cross Blue Shield PPO, HMO plans that are under Medicare Advantage. However, given the population of TAVR patients, Medicare fee for service is obviously the dominant payer here. And given that there was no shared unique identifier between the Tavr registry and the Michigan Value Collaborative Registry, we used 5 different variables and performed what's called a fuzzy match, essentially allowing some leeway for matching, but only kept unique matches so that there weren't kind of 2 people that went to the same hospital, had the same gender, had the same date of birth, and had an admission date within 5 days of each other. If those 2 people were there, we kind of threw both of them out of the study set. And at the very end, we included patients who were discharged only to home. And that's pretty standard when looking at cardiac rehab literature, given that our landmark analysis was whether they went to cardiac rehab within 90 days or not. So we didn't want to disadvantage hospitals or sites if they were sending patients to nursing homes after a complication, or obviously if a patient died, they wouldn't be going to cardiac rehab. I'll very briefly touch on the methods and try to get to the meat of the results quickly, but we performed essentially a sequential random effects regression model with a random effect for hospitals, so trying to account for hospital variation, and fixed effects to account for patient characteristics, socioeconomics, and clinical factors. And you can see here that there was 3 models. One model that just included the hospital random intercept. This allows us to really understand measures of hospital level variation, but not adjusting for patient factors. So not adjusting for the fact that some hospitals maybe care for sicker, more frail patients than others, potentially. Model 2 is where we included patient demographics, socioeconomics, and clinical factors. And then model 3 should actually read model 2 here, same as this one, but then we added some hospital characteristics. And these are primarily measures of hospital quality as determined from the HCAHPS survey, which is, as most of you know, a patient survey where they fill out their experience with the hospital. And prior work that we've done looking at cardiac rehab attendance after PCI has seemed to indicate that hospital quality, particularly around explanation of discharge instructions and post-discharge care, do seem to correlate with cardiac rehab utilization post-hospitalization. Jumping to the results, there were 3,372 patients in the study cohort, and we were looking at if they went to a single cardiac rehab visit within 90 days after discharge. And again, these are patients discharged home. And the overall participation rate after Tavr was 30.6%. This is pretty similar to what we see after PCI and other percutaneous intervention. Statewide, it's around 28.5%, if I recall, with the years being slightly off as to this study cohort. And the other thing that I think is important to note is the decline in cardiac rehab utilization in 2020. And this is a COVID effect that's seen across all conditions, not just TAVR, obviously with many cardiac rehab sites being closed for 3 to 6 months in Q2, Q3 of 2020. And this only goes through Q2 of 2020. So essentially March onward, most cardiac rehab sites in the state of Michigan were not enrolling patients. Very few were doing so for virtually. Here's some baseline characteristics stratified by if patients went to cardiac rehab versus not. And I'll just point out a couple of important findings. As Dr. Arnold noted, Michigan's no different than TVT. The vast majority of patients undergoing TAVR are Caucasian. However, there was a slight difference in cardiac rehab participation by race. Cardiac rehab participation varied substantially by Medicaid coverage. So if there were dual eligible patients. We also noted patients who are smokers were much less likely to go to cardiac rehab, as were those who are currently on dialysis. These were all pre-procedure variables. And I just selected a handful of other important variables here as well. The higher NYHA class, particularly NYHA 4, were less likely to go to cardiac rehab than the other NYHA classifications. And then among patients with atrial fibrillation, atrial flutter, which is a pretty substantial number of patients overall, over 1,000 patients in the cohort. But those with AFib flutter were less likely to go to cardiac rehab. looking at just a couple of, I think, important variables that we included in the study, stratified by STS risk score, baseline KCCQ overall score, and baseline 5-meter walk times. You can see here that there's as STS risk score increased, the percent of patients undergoing cardiac rehab within 90 days decreased. Not surprisingly, this may be because they're frail, maybe because of other comorbid conditions. However, there's again this risk treatment paradox. They potentially may also be the patients most likely to benefit from rehabilitation. And ultimately, we don't have the data yet to demonstrate this, but that we have ongoing work to try to demonstrate what the effect of cardiac rehab is on 6-month and 1-year outcomes, particularly KCCQ scores and mortality. And then looking at baseline KCCQ scores stratified by quartiles, those with higher baseline KCCQ scores were more likely to go to cardiac rehab than those with lower KCCQ scores, again, following the NYHA example I gave on the prior slide. And then finally, the longer 5-minute walk time, so the slower walk gait speed, more likely to be frail patients, were less likely to go to cardiac rehab, again, demonstrating a population that may stand to benefit the most. And indeed, many of the authors from the JAMA paper I'd shown earlier in the slide conducted a study based on randomized Tavr data demonstrating that improvements in gait walk speed after rehabilitation were correlated with improvements in quality of life and mortality. When looking at the final adjusted model, so adjusting for all these factors on the left, and I apologize for the somewhat messy nature of the slide, but you can see many demographic factors, insurance factors, HOMO2 use, dialysis use, hemoglobin, prior history of stroke, NYHA class, AFib flutter, and then looking at including KCQ score and 5-minute walk times, and then post-procedure complications. The arrows point to the statistically significant fixed effects in this model. And I'll just highlight a couple of important ones. Those on dialysis were much less likely to undergo or to go to cardiac rehab, kind of adjusting for all the other factors. Smokers, patients with atrial fibrillation, atrial flutter, 5-minute walk time. So the slower the gait speed, the less likely they were to go to cardiac rehab after adjusting for all other factors. And then we did a principal component analysis to include all the different variables used in hospital satisfaction, but suffice it to say, it essentially becomes a composite score, if you will. And what we found was that, again, a hospital measure of quality, and the higher the score, the lower the patient's assessment of quality was associated with decreased likelihood of going to cardiac rehab after Tavr. What's interesting is many of the post-procedure complications didn't pan out as being statistically significant. I think there are two primary reasons for that. One is we limited the sample to patients who were discharged home, and many of these patients, particularly, for example, if they had a disabling post-op stroke, were probably unlikely to be discharged directly home after their hospitalization. So there's a bias there for sure. And the second one is you can see these relatively wide confidence intervals. These complications, albeit can be catastrophic, are relatively rare, and our sample size isn't as large as the overall national TVT, which is in the hundreds of thousands. Looking at hospital variation, this is just the raw rate stratified by hospital. These numbers don't represent anything other than the rank ordering of a particular hospital. And it ranges anywhere from 5% of post-Tavr patients going to cardiac rehab within 90 days, all the way up to 60%. Pretty dramatic variation that actually, when comparing it to PCI or even cardiac surgery, is a much wider variation than what we've seen in other conditions in the state of Michigan. And then if you can recall, going back to the original models, excuse me, the median odds ratio, which can be kind of interpreted on the same scale as an odds ratio for, excuse me, fixed effects, essentially the idea of what's the odds of a patient kind of holding all the other variables that you've adjusted for constant, going to cardiac rehab if they were discharged from one hospital compared to another one. And if you did that simulation across all pairs, what's the 50 percentile, what's the median odds ratio of that kind of exercise? And you can see here a median odds ratio of 2.1. And the idea being that if there was a dramatic effect of patient case mix, so patient severity, their age, hemoglobin, AFib flutter, all the factors that we noted may be related to downstream utilization of cardiac rehab. If there was a differential preponderance of those patients at certain sites, you would expect that by adjusting for those things, the median odds ratio should go down. The variation across hospitals would be partially explained by those patient factors. And we actually did not see that. So those patient factors, albeit some of which may be predictive of a patient going to cardiac rehab, did not explain away a substantial amount of this hospital variation that remains. And when we included some hospital level factors like hospital quality, some of the variation was explained, but there was still a decent amount of residual variation in terms of the median odds ratio of 1.9 across sites. So some conclusions, many of which I've spoken about. Only 30% of patients who undergo Tavr attend cardiac rehab within 90 days. This is far below the Million Hearts Initiative goal of 70% of patients going to cardiac rehab after a qualifying condition. You can see the many factors are associated with downstream utilization. Many patient level factors are associated with downstream cardiac rehab utilization, many of which have been shown for other conditions, particularly PCI. But I found 5-meter walk time to be a particularly interesting one, given the potential for benefit for patients with a poor 5-meter walk time if they go to cardiac rehab and improve their exercise capacity, as well as the other ancillary benefits of going to cardiac rehab. And hospital quality as measured by patient surveys associated with downstream cardiac rehab use after Tavr. There was substantial variation in cardiac rehab use across the 24 sites performing Tavr in the state of Michigan. And it persisted after accounting for what I believe to be a pretty comprehensive set of patient case mix variables. I think these findings suggest that variation in cardiac rehab is not due to significant differences in patient case mix, but may be related to differences in hospital quality and processes of care, two important targets for future interventions to improve cardiac rehab participation after Tavr. And in the final 2 minutes that I have, I'll put in a quick plug for each site trying to connect with I think MISHC actually is in a really unique place because it inherently brings together interventional cardiology and cardiac surgeons, two of the kind of departments or provider groups that are frequently responsible for getting their patients to cardiac rehab. I think the last kind of key to that is either the local cardiac rehab or the partner cardiac rehab that many of the sites have themselves. And over the past year and a half now, we've been putting out this cardiac rehab hospital level report. And by we, I mean, it's been a really nice collaborative project, but a lot of the person power is coming from the Michigan Value Collaborative, including these great reports that try to stratify cardiac rehab use, or at least provide sites with their cardiac rehab use after PCI, after Tavr, after CABG, after SAVR, for a way to comprehensively look at how your hospital is performing and ways in which you could maybe align with other components of your hospital, including your cardiac rehab sites, to improve the referral process or even translating the referral into actual utilization. We've formed a collaborative across the state looking at ways to improve cardiac rehab overall, not just for Tavr, but all conditions, and have put together a best practices toolkit that will be published online shortly. And we have some statewide cardiac rehab quality improvement initiatives. I hope this at least stimulates some discussion, if not today, but internally within your own group. And if there are any ways that we can help, either through MISHC's coordinating center or through this cardiac rehab initiative that we have throughout the state, please don't hesitate to reach out. Thank you. Any questions? And I see one here from Stan Kakuti. Does inpatient coaching prior to discharge have any effect on cardiac rehab participation? Do hospitals that perform well do this? This is a great question, Stan. There is this idea of a cardiac rehab liaison, which isn't quite, I think maybe we all have different definitions of coaching. It's not quite coaching. It's actually not only providing information to the patient, but also help facilitating that first appointment even prior to discharge. And it does require FTEs, and there's hospital expenses, and all budgets are constrained. There is evidence for the benefits of a cardiac rehab liaison, and there's certainly really good evidence. A nice circulation paper published by Dr. Katayan and Quinn Pack a couple of years ago, looking at what the effect of getting their first cardiac rehab appointment date and time scheduled before discharge has, which is pretty impressive. And I do think Tavr, as opposed to say PCI, for example, which many of us are familiar with, most of Tavr's elective, and so we do have the opportunity to not only provide multidisciplinary shared decision making, but have some lead up time to talk about what they should expect after their procedure, including cardiac rehab and what that rehabilitation looks like. I should put a plug in. Our surgeons statewide do a great job of getting their patients into cardiac rehab. And by a great job, I mean upwards of 50% on average are getting to cardiac rehab. And interestingly enough, there's a big push to get people into cardiac rehab really early. Many of our surgeons have very high rates of cardiac rehab use, but do it at that 30-day visit. But I also think there's a role, and I'm happy to hear from surgeons who are on the call. Maybe I'm just asserting this without knowing, but I think a lot of it has to do with the education prior to their surgery about what to expect post-procedure. And I think we could take that out of their playbook, if you will. Dr. Patel writes, was there any variation in ability to deliver cardiac rehab, i.e. are there cardiac rehab deserts? Good question. We did adjust, the state of Michigan has over 80 cardiac rehab sites. And so we did adjust for the patient's zip code centroid, which is a pretty inaccurate measure of distance or of starting point, if you will, to the actual cardiac rehab address, using driving distance, not the whatever the term is, the straight line bird flies over the path. There's a term for it. And by adjusting for that, one, it wasn't significant in terms of that distance being significant for this population. But overall, there are cardiac rehab deserts across the United States. I think that's been well delineated. But it doesn't appear to necessarily be the issue in the state of Michigan. I think transportation can be an issue. And there are many barriers to cardiac rehab, including the times that it's offered. It's typically in center, virtual is not offered at many sites. And then lastly, transportation. Many of the patients aren't driving themselves, need to find someone to drive them. That person may work, and therefore it can be inconvenient. Did the same hospital with poor results do well in their ability to have patients undergo cardiac rehab after cardiac surgery? Good question. One of my colleagues, Mike Thompson, has done some work on this, just using the administrative claims, which are very rigorous and robust. And there does seem to be a kind of hospital level cardiac rehab effect across domains, be it the procedure or the department. So PCI, AMI, CABG, Tavr, SAVR. Hospitals that tend to do well in one tend to do well across those conditions. So it kind of seems to be a hospital level process rather than a service line level issue, as best as we can from the empiric data.